Can you imagine having a specialty that people always get wrong, that you always have to correct them on? You may be wondering, well, what specialty is that? I'm talking about thoracic surgery, not cardiothoracic surgery. I think most of us are familiar with CTS, but this is actually just thoracic surgery. Honestly, I didn't even know that that was a specialty just in and of itself. And if you're like me and really don't know about it and want to learn more, then stay tuned because I have an interview with a PA who has been working in thoracic surgery for like 20 years. So she knows the specialty pretty well. She's going to tell us all about it, what they actually do, how they're different from CTS surgery, and what it's like to work in this specialty. Hi, my name is Michelle, and I'm a PA, and this is the Medicine Couch. On this channel, I help PAs and NPs to discover all of the amazing opportunities we have in and around medicine. I also talk about PA and medicine specific topics from time to time. If you like what I do and you want to help support the channel, please hit that subscribe button. It really does help the channel out. And if you find my videos interesting and know colleagues that may benefit from them, please share them. Now, let's head into this interview and learn about thoracic surgery.
Hi, everybody. My name is Nicole Larson. I'm a PA in thoracic surgery, and I've been a PA for about 18 years. I'm really excited to talk to everybody about our unique subspecialty and inform everybody what we're all about.
You know, my whole career, I've always heard of cardiothoracic surgery. It's not cardiothoracic surgery, right? It's just thoracic surgery, correct?
It is. So while those two specialties are often linked together, and certainly in maybe community hospitals, a lot of times those departments will do both. In a lot of larger academic settings, as things have gotten more and more subspecialized, you are seeing a differential between cardiac surgery and general thoracic surgery. And we do have completely different disease processes. I've never been in an open heart surgery. We're really just focused more on the non-cardiac chest surgery and as well as some foregut surgery.
I'm curious, you said your entire career has been spent in thoracic surgery. Was it something you even knew about when you were in PA school, or how did you land in this position?
It was completely by luck. When I graduated from PA school, I knew that I wanted to relocate back to a city closer to where I grew up. And I looked for jobs and I interviewed, and one of them was in gastroenterology in the suburbs, and one of them was in thoracic surgery and lung transplant in the city. And the city won out, and I just have never looked back since. I just absolutely fell in love.
Tell us about thoracic surgery as far as what kind of surgeries you guys actually do.
Sure. So, like I mentioned, we really do all chest surgery that's non-cardiac, although a lot of thoracic surgeons will also dip into pericardial effusions and pericardial windows. I've had some that have done pacemakers as well, just depending on the scenario of the hospital and the needs of the hospital. The main bread and butter of our patients are lung cancer patients. We also deal with pleural effusions, mediastinal lesions, and then we do foregut. So we do esophageal cancer, we do large paraesophageal hernias, and a whole smattering of other things that go around those two body cavities.
That's interesting because I never would have thought if you asked me to name what you probably did in thoracic surgery, I would never have thought about the esophagus and all that because you tend to think that like is more GI. So that's interesting, almost a little blending of those two. So I assume you work in a larger institution and you guys have cardiothoracic surgery and thoracic surgery. Is that correct? How did they determine which patient goes to CTS and which ones go to thoracic surgery?
Well, again, because the disease processes we take care of are so completely different. We're literally two separate teams at my institution, as was at my prior institution. Again, you might find teams where they do both. I certainly know people across the country where that is the case. But yeah, in our institution, there's really very little crossover, to be honest. Maybe pericardial effusions is the one thing where, again, cardiac surgeons, could certainly attend to that. But at least at our institution, they're not doing lung resections, certainly on a routine basis at all, and definitely not dealing into the foregut stuff. So it is completely separate. We have separate teams. Our cardiac surgeon team has 3 surgeons and 5 PAs, and the thoracic team has 2 surgeons and 4 PAs. So yeah, we're completely separate.
Are you doing transplant surgeries?
Not at this current institution. That can be obviously part of the thoracic department.
So where you work right now in your department, you said there's 2 surgeons and there's 4 PAs. Are they all PAs or PAs and NPs mixture?
So we have 3 PAs and we actually have one very awesome NP. She does focus more on the outpatient side. She does cover some hospital weekend call, but the 3 PAs are the ones responsible for actually operating with the surgeons.
Okay, so in your group, the NP is choosing to do outpatient, but obviously NPs can be found in the operating room in certain different teams too. How do you guys divide up duties? Are there any that are always just in the OR and some that are just like the NP that are always outpatient, or do you guys kind of mix it up a little bit?
We do rotate. So typically, the PAs, one of us will be kind of assigned a clinic for the week, and the other 2, it's not necessarily all OR that week versus all inpatient, but kind of a mix depending on, the acuity of the surgeries. Obviously, it's a mentally and physically taxing thing at times. So sometimes we'll alternate days, things like that. But generally speaking, I'm on the inpatient OR side for 2 weeks and then have a week of clinic and then go back to inpatient OR. So the last few days I've been doing inpatient, but I scrubbed for an esophagectomy on Monday. So a little bit of variety.
Ectomy means removal. Are you actually removing people's esophagus?
Yes, we are. So that surgery is typically done for a malignancy, although it can be done for certain end-stage benign disorders such as achalasia, which we also do treat. We do myotomies for achalasia and also a lot of reflux and hernia repairs. So esophagectomies in some ways are a lot like gastric bypasses in terms of, we are really altering the anatomy. But yeah, we do remove the esophagus from about the mid-chest to the upper part of the stomach and then reconstruct the stomach into a neo-esophagus, making it's the new tube, and then have an anastomosis in the chest. So you can see why that's such a long surgery. There's a lot of steps.
Okay, well, that's interesting. Thank you for sharing that with me. Now, as far as patient population you guys see, is it all adults or do you guys do a mix of pediatric and adult?
We really don't get too much into pediatrics. We might get some, late teenagers occasionally with like spontaneous pneumothoraces, things like that, some pneumomediastinums, another common consult that we see. But generally speaking, we're adults and older adults, although I will say, unfortunately, we're seeing a lot of younger folks with lung cancer in their 40s and 50s.
So on the weeks that you are inpatient, are you rounding on patients as well as working in the OR? Do you do stuff in pre-op and post-op as well?
Yeah, so inpatient, we're generally responsible for rounding. Again, the hospital I'm at right now, we do not have residents or fellows or anybody. So it is a PA-run service, both in the OR and on the inpatient side. So we're responsible from everything from rounding to placing orders, removing chest tubes, discharges, all of that. Of course, depending on the census that any particular day, that can take several hours to all day, or that may be a shorter amount of time. And if that's the case, you might float into the OR, or we have clinic 5 days a week, and the APPs kind of share a schedule. So even though our NP typically sees most of those folks, we certainly pop down, see a couple patients, or jump in on the physician's schedule and see some patients with them. So there's always something to do.
And are you guys doing consults at all?
We would take care of any consults for the floor. We do have a second hospital that we still are responsible for consults for too. So sometimes you're scooting over there on your way into work or scooting there on the way home or trying to field phone calls in between. So there's a lot of coordination that way too.
And speaking of phone calls, do you guys take call or is it common to take call in thoracic surgery?
I think it's getting more and more common, particularly on the PA run services, where you don't have residents and fellows that are in-house to take call. The way we've got it set up with our group is our physicians take weeknight call, and then the 4 of us rotate through on weekends. So Friday at, theoretically 5 p.m. till Monday at 7 a.m. We take first call. Now, of course, we always have to have a surgeon on call with us, but we take care of all the rounding, all the phone calls. We'll get the ER phone calls in the middle of the night. Just give them a little bit of a reprieve from those, can I order the patient Tylenol type of phone calls.
And then in the office, are you doing initial consults with patients or are you only seeing the patients after they've seen the surgeon? How does that work?
Yeah, so it's a little mix of both. With our lung cancer patients, we have a lot of longitudinal follow-up. So the APPs are seeing a lot of those 1 year, 2 year, 3 year post-op patients, monitoring for recurrence or monitoring for a new primary lung cancer. So while we might be seeing a lot of follow-up patients, we certainly do find new problems in that, and then we'll proceed with the workup that's appropriate. We do see some new patients independently as well. Specifically, we see a lot of lung nodules. We manage a ton of lung nodules in addition to our lung cancer screening program. Not all lung nodules necessarily need a surgeon. And so a lot of those folks will come in and we'll be able to review their CT scan with them, talk to them about nodules, talk to them about the risk factors. If they're a smoker, we really work on smoking cessation. And those folks, we can set up the follow-up plan for them without necessarily needing to have the surgeon involved. And then we do have the surgeon has clinic, right there at the same place for the 5 days of the week. So a lot of the new patient consults will be on their schedule. However, we'll see them with them, normally beforehand and then present to them. So you do get a pretty good mix of everyone. And we'll see post-op patients on our own, and go through all of their pathology and things like that. So it's a pretty good mix.
So when you're in the OR and you're first assisting, what kind of things are you doing? Are you mainly just holding retractors and suctioning, or are you in there actually doing more advanced things?
So because, again, we're a PA-run service, we don't have those trainees with us. We are the bedside assistant. We do the majority of our surgery robotically. So the surgeons at the console, we're at the bedside. A lot of times we're doing, passing them different suture or changing out the instruments, suctioning, like you mentioned. But on lung resections, we actually do the stapling. So there is a stapling device that can be used with the robot arm that the surgeon would control, but we find that it's more efficient for us to use what traditionally would have been done with thoracoscopic or, minimally invasive but non-robotic surgery. And so we actually run that stapler. So we are stapling lung parenchyma, we are stapling pulmonary arteries. That's a pretty intense job to have when your surgeon's sitting 15 feet away from you, and if that vessel bleeds, we're in big trouble. So it is actually quite empowering to learn those skills. And compared to my prior positions where I was in a university setting with trainees, it's been a new adventure to learn all those skills, and really kind of gives you a real sense of autonomy to be able to operate at that level.
How do you learn that? I mean, we obviously learned surgery in PA school, but not specific things like that. Do they have mannequins and different things you practice on, or is this just kind of learning as you do each surgery?
Yeah, so I mean, I had the benefit of at my first position getting a lot of second assist time. So even though that was a university setting with residents, we always had two people scrubbed for surgeries, two assistants. So that's kind of where you get your feet wet and learn all the steps of the operation, obviously. And at that time, it was a lot of laparoscopic or thoracoscopic surgery, so learning how to drive the camera, et cetera. And that kind of continued through my second position, which was the longest of my career, which was about a decade or so, where I did get to scrub more and more, occasionally as first assist. And yeah, you just kind of watch and learn. And almost at some point, you could teach the residents, even though you didn't necessarily do it yourself. You just knew it so well. I hadn't done the robotics previously, though. So that was definitely new for me to have to be the one at the bedside doing it without the surgeon necessarily holding your hand, so to speak. And luckily, I just had a surgeon that was really good at working with us and actually empowering us. And so that was very helpful because it is a really vital and serious part of the operation. And you can't be scared, right? You have to be confident, but yet cautious appropriately. So just good training. And luckily, I came into it with several, many, many years of experience.
I guess the moral of the story is that if you are going for any kind of surgery type job, well, really any kind of job in medicine, but especially surgery, when they're going to be expecting you to be in there first assisting, is to try to always find someone who loves to teach, right? To find a surgeon who's going to, like you said, empower you and help you learn.
Or some great, PAs or even, I mean, I learned from residents, everybody. I mean, just trying to take as much from every person that you run into, even some great scrub techs, nurses, everybody really helps you to form that confidence that you need to perform at that high level.
So you said you feel like you have a lot of autonomy at times, in the OR because you get to do these other procedures. And do you feel that way in clinic too? Do you feel like you have a fair amount of autonomy?
Absolutely. Again, this particular position that I'm in now, we do see so many patients on our own as well. The same surgeons are constantly asking us to use our higher level thinking and independent thinking, and are kind of expecting us to really come to them with the plan. I mean, obviously, ultimately, the decision for surgery lies with them, but I would say probably 99% of the time I have exactly what they're going to do. And I've already told the patient that's what we're going to do. And they kind of just come in and say, this is what we're going to do. And they say, okay, Nicole already told me that. And obviously, a lot of that's the years of experience. But yeah, that really has been a great part of this job, is being able to act that autonomously. And it was there before, but specifically in this job because we're seeing so many patients independently.
Can you give us an idea, like in the clinic, like in a typical outpatient day clinic, what's kind of the range of the number of patients you see outpatient? And then we'll talk inpatient in a minute.
Outpatient on a non-physician day, so just like an APP clinic, we probably see anywhere between 10 and 15, which may not seem like a whole lot compared to a lot of other specialties, but we do have a lot of chest tube removals, things like that in the office, and there's x-rays and things, so that does take quite a bit of time. When the surgeon's also participating in clinic, we can probably go anywhere from that, minimum of, 10-ish all the way up to 30 in a day, 4 days a week of that. So it's a pretty busy clinic.
That was one of the questions I was going to ask you later, is in-office procedures. So you remove chest tubes. Any other procedures that you do in the office?
Not too much, just removal of tubes normally, JP drains, J tubes, things like that. Because it's so minimally invasive, there's not a whole lot there.
All right, so then going to the inpatient side, in a typical day, like how many patients would you have to round on? And then how many surgeries do you typically do in a day?
If we're talking lung resections, hernia repairs, those types of surgeries, those are a couple hour surgeries each. We normally would do 2, maybe 3, quote, bigger cases a day. And then we have a smattering of smaller cases, such as bronchoscopic biopsies, port placements, that type of thing. Or we could have a day where it's all little stuff, quote, little stuff. We might do 6, 7, 8 cases. Esophagectomies are probably our biggest case. And normally those are scheduled for just that case that day, because it is a 6 to 7 hour surgery. Although lately we've been cramming some other stuff on top of that as well. Our inpatient census tends to stay fairly low because our patients don't stay in the hospital that long. We have really, especially since COVID, been trying to get our patients out relatively quickly. We've been utilizing different techniques to try to get them out earlier, such as discharging them home with a chest tube that they can then just come to the office the next day or two and get removed. But our patients generally stay for, say, a lobectomy for lung cancer. 1 to 2 nights is our average length of stay. And so I would say our census is generally around 10, maybe, including consults and, some folks that maybe stay around a little bit longer. But yeah, hopefully by the weekend, we've kind of cleared it out for the person to be on call. That's always our goal.
I mean, the hospital is no place for people to be if they want to be healthy.
Exactly.
I know they need to, there's times you need to be in the hospital, but you don't want to stay there any longer than you have to. So this has been your only specialty that you've worked in since school, and you really know it inside and out, which, by the way, I was going to say earlier, I'm a person who likes variety and likes change and stuff. So I don't know that I could ever work in a specialty for 20 years, but I do see, like when you were talking about gaining that confidence and that autonomy, I was thinking, man, that's got to be a great feeling when you know your specialty inside and out. And it really takes those years, right? Those years of experience. So definitely something to be said for sticking with a specialty and really learning it. Do you agree?
Yeah, I do. Yeah. And, I think what's interesting about thoracic surgery and what I love about it is the variety. You think, you've been doing thoracic surgery for so long, but there's just every day is different. We see so many different disease processes. And then honestly, we use a lot of medical knowledge too, right? Between inpatient management of different disease processes. A lot of our patients are not healthy patients. So there's a lot of things that go into this that we have to think about. It's not always the patient needs surgery, but can the patient withstand surgery? And that's the biggest job that we have as the PA when we're going to present the patient to the doctor.
Any other positives or things that you really love about the specialty you want to mention before we move on to the negatives of it?
I think, again, for me, I always had an inkling towards oncology things. And I think that's one of my favorite parts about this. I know that might sound horrible. No one really wants to have cancer or talk to people about having cancer. But I do find that is a very rewarding part of our job. We have the gamut. We have people that we're theoretically curing with surgery. And then we have people that maybe we're not going to be doing surgery for a curative intent, but we're just helping them on the path to diagnosis, or maybe it's a port placement or palliative procedures to control symptoms. And so I really do enjoy that part of it. And I think the reward really comes, again, in that longitudinal follow-up that we see these patients years and years later. And eventually I say, I hope our conversations really focus more on where you went on vacation and what books you've read lately. And then we say, yep, your scan looked great, and you go on your way. But that part of it is certainly rewarding.
Every specialty has things about it that are downsides or negatives to it. Anything like that you want to highlight or tell people about?
It's a pretty good specialty overall, but like most surgical specialties, I think job wise, you have to realize that you're going to work till the work's done. Just because my punch card might say that I'm done at X time, if the surgeries are still going on, especially in a setting where we're the first assistants, right? There's no resident to say, "Oh, tap, you're in," So we are responsible. I've been at work from 7 a.m. till 10:30 at night sometimes. It doesn't happen too often, luckily, but certainly there's that aspect to it. I think earlier in my career, I did find some frustration working in settings where maybe you were dealing with trainees. I don't want to make it sound too negative, but it is always hard to be second fiddle or having folks jump ahead of you in line, so to speak, even though maybe you've been around longer. And that certainly wasn't all of them. There were some that were absolutely a joy to work with, and they looked up, to us as the extenders with great reverence because they knew we had a lot of the answers that they needed. But some, really just didn't have much regard for your opinion and input, and that got frustrating, especially the further on into my career that I got. That's probably, again, more generic in terms of any type of person that's working with trainees, but that's been my experience and probably the only thing that's really stands out as a negative to me.
You talked about that the hours sometimes can be long if you have a long, surgery that's going long. Can you give kind of an idea of what your hours typically are, maybe a clinic week, and then what your hours usually are when you're in a hospital week?
So hospital weeks, we're generally starting somewhere between 7, OR starts at 7:30. So sometimes I'm kind of sneaking in the door at 7:15. And I'd say generally speaking, we're wrapping things up by 3:30, 4 o'clock in the afternoon. On a clinic week, that's another reason I like this rotation because it is the one week that I get to sleep in at least a few days of the week because I will come in a little bit later, say 8 o'clock. And that day normally is again going till 4:30, 5 o'clock kind of at the latest.
I assume you have to chart the surgeries and things, at least your part in it, or how much charting do you have on the inpatient side?
So we do all the progress notes, discharge summaries, make sure all the H&Ps are up to date. Obviously, consults write the consult note and progress notes on those folks. Surgery-wise, the doctors do most of the documentation, and then we're responsible for all the orders.
What kind of personalities do you think do well in this specialty?
I think all surgical specialties, you do have to have a pretty calm demeanor. You do have to be able to go with the flow, right? Things happen in surgery, things happen with consults that you have to discern. Are they something you need to see right now, or do they need surgery now? Is it something we're just going to follow up? So you have to have some calmness about you and just kind of be able to go with the flow. I alluded to the fact that, we do some pretty dangerous things in surgery. And unfortunately, stuff does happen and you have to be able to keep your wits about you, especially when your surgeon's 15 feet away from you, not at the bedside, right? So yeah, a lot of calm and collectedness helps. In this particular specialty, because we deal so much with cancer, I think you have to have an ability to talk about those things in a calm and I don't want to say non-emotional way because I certainly try to connect with the patient, but I also have to, I can't be crying and things like that to them. So that does take some time to hone in on those skills. And then I think education, we're talking about cancers, we're talking about whatever disease process, lung nodules, lung cancer screening, smoking cessation, all of those things. You have to have the heart of a teacher to really connect with the patients.
So money is not everything, but money is important. Can you give us an idea of what people could expect salary-wise?
It is hard to find thoracic surgery data compared to CT surgery. I mean, we're still lumped in with them, generally speaking, in terms of salary reports and questionnaires and things like that. So it is hard to kind of fester out just the thoracic folks. But I do think generally speaking, you'll find if you have a tier system in your hospital, you're going to be one of the higher tiers. Generally speaking, the range that I've seen is probably somewhere north of 110 to 150. And I think that's probably very conservative. It depends on obviously your setting, what those job responsibilities are. And then also, your physical location and your region.
So if somebody wants to transition into this specialty, if they're working in something else, or if they are coming out of school, any tips that you can give them, any ideas on how that they could prepare themselves to work in this specialty?
A big part of our job is radiology, really learning how to read CT scans to the point where, maybe you're calling the radiologist and asking them to redo their report because you saw something they didn't. So that definitely helps if you really get some good baseline knowledge in reading chest CTs, and then just learning the disease process and kind of knowing the staging of the cancers is probably one of the biggest things.
What about like societies or conferences or anything like that? Is there anything you'd recommend there?
There's a great society that I have participated in for many years. It's the Association of Physician Assistants in Cardiovascular and Thoracic Surgery. And we have an annual conference that I've actually was the co-chair of the thoracic track for last year, and I'll be co-chairing again this year.
You came out of school as a new grad straight into this specialty, right? Is this something you would recommend?
This specialty is fairly new grad friendly. It really is a specialty that's really driven just by your basic, really good interview skills, and then some added skills, obviously, with the surgeries and radiology and things that just take time. But I think if you have a setup where you have some more experienced APPs or certainly physicians that are willing to train people, that it actually can be quite new grad friendly.
If you're interviewing for a position and you want to make sure you get into a position where they're going to give you good training and guidance, what kind of questions would you ask in the interview?
So I think the number one thing is, again, what the team looks like. I was very fortunate in my first job that I came into a position with a PA that had been there for 5, 6, 7 years. So she was a really rock solid study source for me. There was another PA who was relatively new to that position, but she had a couple of years under her belt. And then actually we had a pediatric cardiac PA that kind of job shared with us and really just taught me so much in terms of medicine and cardiac stuff and medications and AFib and all of that jazz. So I think if you're interviewing, and I always tell my students, you got to find out who's on the team and try to gauge personality in terms of how they're going to be teaching. Do they have that heart of a teacher? And you don't want to enter one of these super subspecialties and be there on your own. I don't think that's an ideal situation. When I've been on the other side, been interviewing for positions, we always offered job shadowing. And if you're interviewing and they don't offer it, you should ask. Just ask to come in for half a day or a whole day and just see what the flow is. I think you learn a lot about the team from just being a little bit of a fly on the wall. And you'll also see, if the people you're working with are going to give you the time of the day or maybe they're not. And that'll tell you a lot about whether you think you're going to fit in with that particular team.
If people are still in school, what other rotations do you think would be the most helpful for them if this is something they want to head towards in their career?
Certainly pulmonology. Like we mentioned, also the GI side of things. Certainly my background with having some oncology was useful as well. And then finally, the one rotation that I honestly wish I would have had that I didn't have was ICU.
Anything else that you want to say?
That we are our own specialty, that we have a lot of skill to bring. My plug would be please, 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 if you're in primary care or really any specialty, if you have smokers, please encourage them to go get lung cancer screening done. Current recommendations are age 50 to 80 with a 20-pack year smoking history, and they have to have quit within the last 15 years or be a current smoker. Hopefully that's going to change a little bit, but that's my plug for lung cancer screening.
Great. Well, thank you so much, Nicole. If you're looking for information about other surgical specialties, then watch these videos here. Thank you so much for watching. And as always, take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.